All right, you can tell we've spent a lot of time with each other over the past few days. Thanks, everybody. First of all, thanks for having me today. Big shout out to the team from the Global Health Connector on putting together just a fabulous couple of panels. So I've really enjoyed that. I'm Eric Threlkill. I've been a CIO at 3 different provider organizations, chaired an accelerator program called Project Healthcare, a venture partner in 2 different digital health funds, and now I'm the founder of an organization called Day 24. Love to tell you about that, and an ambassador for the health community. I'm from Nashville, the home of a fairly robust healthcare ecosystem dating back 55 years. Over 500 companies, 17 of which are public, over 300 individuals work in the healthcare industry and in the Nashville community, and an ecosystem that includes investors, mentors, advisors, startup organizations, and storytellers for the industry. The book Superconvergence is a favorite of mine. The author, Jamie Metzl, talks about 100 years ago, we had about 2 billion people on the planet with a combined 15% literacy rate. Now we have about 8 billion, about an 85% literacy rate, and we're connected. In addition, in just the last 25 years, we've seen explosive innovation in genomic sequencing, biotechnology, certainly significant large data sets powering artificial intelligence in many different categories: predictive analytics, NLP, computer vision, and certainly generative AI. This has led to an accelerated rate of innovation. Who knows what's going to be presented and talked about just this week while we're at the health event. Almost every day, new innovations are occurring that just at a staggering pace. However, it's really challenging to bring those very innovations that could drive significant value to all the stakeholders in the industry, and to be able to do that faster. And so I credit organizations like the Global Health Connector and others that are responsible for bringing together the various components of the ecosystem. So I'm pleased to moderate this panel. I'm going to let each of the gentlemen here say a few words about their organizations, and then we'll dive into some Q&A and be thinking about a question or two if we have time at the end of the panel. So Dr. David Reich of the Mount Sinai Health System is with us, Andy Arlock from Helpful Engineering, and Sanjay Parekh of Perspectum. So we'll start it off with Dr. Reich.
Thank you, Eric. So as we get started, I'm going to be showing a few slides here. Let's see if this works. And I wanted to give complete credit to Robbie Freeman, my colleague, who has been a partner since 2016 in building clinical decision support at Mount Sinai. I'm here also representing Mount Sinai International because what we're thinking about today, and as I give you these very brief examples, I want you to think about the environment that we can create that can bring clinical decision support on a global scale. No disclosures related to this presentation. Now, we're perhaps several centers in the US and Europe and elsewhere a bit ahead of the curve in terms of creating clinical decision support using internal resources. Of course, there are many startups in this area as well, and slowly over time, we're seeing that core products like the electronic health records will start to incorporate some of the clinical decision support applications. And I'm just going to touch on 3 of them very briefly today: malnutrition, delirium, and deterioration. So for clinical deterioration, actually it took us some time to get this published, but just earlier this year, we were able to show in a paper published in Critical Care Medicine that clinical deterioration alerts that were developed internally and tested in a prospective fashion were actually able to be of some benefit. And if we look at the results slide right here, what you see when we look at the section B, which is the secondary outcome of in-hospital or 30-day mortality, where we studied 2,800 patients, and some of them were on units where we suppressed alerts, and some of them were in units where we sent alerts to the nurses or to the rapid response team. And in the 2 units where we were able to get those alerts to the team and built it into their workflows, what we saw was a 24% reduction in mortality in those 2 units. Now, one thing that's important here to also keep in mind is over the course of 5 days, 92% of the patients had some form of alert. The low-level alerts got the nurses to check vital signs every 1 hour for several hours, and the higher-level alerts summoned the rapid response team out of the intensive care unit. But the point of this is that we were able, as many of you would be able if you set up the right environment, to create a predictive analytics workflow that fit into the clinical workflow, and perhaps most importantly, was seen by the clinical team as actually a positive, something that helped them in their work. I'm going to spend now another moment on malnutrition, going very quickly and through just a couple of brief examples, but to talk about the concept again, that it's partially data science, but it's almost all about the environment, the data science leading to changes in the workflow. Now, this is an important little slide here for a moment. If you look at these receiver-operator characteristic curves, the dotted line that goes diagonally from 0 upward and to the right would be a useless test, no better than a coin flip. But as a predictive analytic tool gets better and better, the yellow curve gets closer to the y-axis and gets almost to the top and then shoots across the x-axis, and that would be an area under the curve of 1.0. So 0.5 is useless, 1.0 would be perfect, and the good thing that worked out here is across 6 hospitals in New York City in the Mount Sinai Health System, the same algorithm actually worked. Now, there's a cautionary tale here. Although we're very happy with our use of Epic over really a long time now, almost 2 decades, what we have seen is that when you try to deploy large-scale models, they don't always work in our environment. And we developed this on local data. There's an aphorism in the U.S., and maybe it's worldwide, that all politics is local. Well, I would argue that all predictive analytics is local, and that we have to take into account there's tremendous diversity in our populations, especially when we consider a global approach. And so the lesson here is that we were lucky this time, but in certain cases, we will need to do analyses based upon local data, and it's frankly getting easier and easier because the science of it, the predictive analytics, in some ways becomes more trivial. Now, why was this important? Well, in the U.S. system, I heard someone before in the back talk about owning a company related to dietary interventions. We have a vastly underdiagnosed epidemic of malnutrition, and you see it in hospitals. It's not inherently obvious. People can be obese but still have severe protein-calorie malnutrition, especially after a situation like abdominal surgery. They may not eat for 9 or 10 days. And so this condition can happen in a way that's actually fairly insidious. And in the U.S. health system, when you code and you treat, most importantly, for severe protein-calorie malnutrition, your observed to expected ratios of outcomes in the hospital are moved in the right direction for a hospital's reputation. And secondarily, what you see is that we're able to, get the treatment to the patients they need and get paid more for it. So we tripled the rate of diagnosis of malnutrition by introducing clinical decision support into the workflow. And every day, the dietitians at the Mount Sinai Health System hospitals are sent to patients based on decreasing order of likelihood that they'll actually have the diagnosis. The algorithm doesn't make the diagnosis. The algorithm gets the team to the right people who are most likely to have the diagnosis. That way we don't run afoul of regulatory limitations. Now, this model is one that predicts delirium. Our previous chief executive officer was a psychiatrist, and he was very much interested in the phenomenon of delirium in hospital settings, which is quite problematic, and it prolongs length of stay. It's associated with worse outcomes. And we had a terrible time, as you can see on the right side of this slide, looking at the orange line and the blue line in trying to get the best levels of prediction. That was using structured data within the electronic records. And the moment we started using natural language processing of the notes, not just the physician notes, nursing notes, notes by physical therapists, social workers, suddenly we had an area under the curve of, I believe it was about 0.93. It's cut off a little bit in the slide, but it was scary, scary predictive. So the point, again, is that if you do it right, it's very easy to bring that team, because we have a team that actually treats delirium in a very large hospital system. You can create those teams, fix the medications, give patients the proper type of therapy. I want to end this little presentation with a data presentation anyway, with a bit of a cautionary tale. A study done in Germany, a group of radiologists, created a situation where you had very inexperienced, more experienced, and really experienced radiologists, meaning residents, junior faculty, and senior faculty, that were reading mammograms. And what they did was they paired them with an AI algorithm, and then they intentionally introduced errors in stage 2 of the experiment. Those red 12 mammograms on the left, they purposely inserted wrong recommendations from the AI algorithm. And what happened was fascinating when we look at this. On the left, when the AI suggests the correct category of the mammography interpretation, everything worked out pretty well. Mean percentage of correctly rated mammograms around 80%. When they introduced the incorrect, it dropped it to about 50% accuracy even for the most experienced users, but look at the residents, down around 20% accuracy. So what it really showed here was that we have a very important responsibility here, because when the AI got it wrong, it led the clinicians to make a wrong diagnosis. So what are the lessons? Bring the right team to the right patient at the right time. AI doesn't make the diagnosis, but in our cans, we like to use it to identify those who are most likely to have the diagnosis. Think of this, especially when we work with our staff. It's not artificial intelligence. It's augmented intelligence that helps our staff achieve the higher patient safety, quality, experience, and healthcare economics. And then finally, the electronic health record is not necessarily going to be the engine that produces the AI, but it's a very effective platform for communication and building it into our staff workflow. So think of it here. It's more than the model. It's about co-designing this. There has to be very little distance between the development team and the end users, agile iteration, robust governance, and it has to happen locally. All politics is local, all data analytics is local, and we have a tremendous future here. Think about this. This can go across all sorts of borders, can cross languages. The key thing here is that we started with electronic health records. In the future, we'll have much more in the way of imaging data, the multi-omics, leading to multimodal solutions, which will further increase the predictive analytics. So I'm going to stop there, and thank you for giving me the opportunity to do a little presentation to get us started, hopefully, and get some good discussion later. Thank you.
Hi, everyone. Good day, and thank you for joining us, and thank you to the ECH Alliance as well for the invitation to be here today. So my name is Sanjay Parekh. I'm a Senior Business Development Manager here at Perspectum, and I'd like to talk to you more about what Perspectum's doing in the precision imaging space. So at Perspectum, we're a global medical technology company that has developed non-invasive imaging solutions to help clinicians diagnose and monitor fatty liver disease and cardiometabolic disease. Our company was founded in 2012 as a spin-out from our CEO's PhD, Rajarshi Banerjee's PhD, from the University of Oxford. And we remain headquartered in Oxford in the UK. Our flagship product, Liver Multiscan, has proven value for risk stratifying and monitoring patients with fatty liver disease. And we've also achieved nationwide payer coverage. Across our product portfolio, we have 24 regulatory clearances with 6 CPT codes, and our technology is enabled at more than 750 scanners in the world. Our proprietary biomarkers are also well validated with an evidence bank of more than 100 peer-reviewed publications. Our technologies enable clinicians to use AI-driven biomarkers to get better clinical decision-making or to make better clinical decisions and ultimately improve patient outcomes. The company initially started off in the liver space, where we looked at chronic disease and fatty liver disease. Before, more recently, we've now expanded into multi-organ imaging, which fits in line with this view of looking at precision imaging, where we're targeting more complex conditions with multiple comorbidities, such as obesity and diabetes. Our broad set of imaging biomarkers are standardized and scalable and have a significant deployment with pharma companies as part of their endpoints of clinical trials. Pharma companies have used us as their imaging endpoints in many different clinical trials. And one notable example was actually from June this year, where Eli Lilly read out the results of their phase 2b study for tirzepatide, and they were using this drug as a therapeutic for MASH, which is metabolic dysfunction-associated steatohepatitis. And Perspectum's imaging biomarkers were used as the endpoints in that clinical trial. So how does our technology work? Our technology extracts quantifiable biomarkers from a traditional or standard non-contrast MR scan. Our technology is standardized across many of the major manufacturers, and our results are returned via our cloud-based SaaS platform to the end user, to the clinician, in the form of an actionable report. And this helps drive better decision-making and more informed decision-making for the clinician to ultimately lead to better patient outcomes. A bit more on our product portfolio. So Liver Multiscan is our flagship solution. This is a solution which helps clinicians manage and monitor fatty liver disease. MRCP Plus is our visualization tool, which provides quantitative metrics to clinicians to help study and manage biliary and pancreatic disease. Hepatica is our oncology solution, and we've started out in the liver, looking at solid organ tumors. And finally, the product which we're very excited about in this move to precision imaging is CoverScan. CoverScan is a multi-organ imaging solution which picks up almost 50 imaging biomarkers across 6 different organs from a single MR scan. All our products are FDA cleared and have CPT codes, and Liver Multiscan and MRCP Plus also have a premium reimbursement from both the CMS and commercial payers. Liver Multiscan and MRCP Plus are also in medical society guidelines in both the US and in Europe. And just doubling down on CoverScan, which we're quite excited about. In a recent study that was published this year, CoverScan was used to profile the metabolic health of diabetic patients. And in this study, 94% of these patients had at least 2 comorbidities or comorbidities in 2 different organs, which CoverScan was really able to pick up nicely. And we're really excited about this as conditions such as obesity, diabetes become global pandemics and an increasing problem. I'm excited to also share with you that our CoverScan technology has also been shortlisted at the Galien Foundation's Pre-Galien Awards coming up later this year. And my colleague Arjun Jaiswal, who's also in the audience, will be sharing a deeper dive on CoverScan and the value proposition that it has at another ECH seminar on Tuesday. So please join us for that as well. Thank you.
Hi, everyone. I'm Andy Arlick. I'm Chief Strategy Officer of Helpful Engineering. And quickly to introduce Helpful Engineering, we're a global community of engineering experts. Those experts we channel into various different engineering opportunities for them to make social impact difference. So it's really about helping the engineers both drive kind of their own personal professional development, as well as being able to work on social impact causes. We work with our members. We're over 20,000 members from around the world right now. And basically, these are independent engineers. We also partner with academic institutions and other organizations that allow our membership to grow and expand. We've been working quite a bit in the healthcare AI space in conjunction with external companies in terms of developing their AI programs. And one of the things that we've seen is that many innovative new solutions, they require quite a bit of leverage to get off the ground, whether it's because they need help in getting to that proof of concept phase or access to infrastructure and resourcing that we're able to provide them in those early stages as they get their solutions more market ready and be able to attract more funding opportunities, as well as more resourcing and partnerships for themselves. So we really help companies and solutions, I would say, in the early stages get to a more tractionable place around healthcare and AI solutions. And I wanted to just make a few kind of more broad comments about healthcare AI. I know, some of the others on the stage have talked about specific solutions that they were looking at, but just some trends that I've seen kind of from my vantage point as a co-development arm, if you will, of solutions that are out there. The first one is that, as we've all seen, everybody's talking about AI and how AI can transform the world. And yes, it has this huge ability to make a huge difference over time in healthcare, as well as obviously all the other industries out there. But one of the things I've understood, and this is coming from my product and technology background, which is really about pushing things forward, is that in healthcare, we really need to kind of slow down in terms of making sure that the practicalities match the hype. In other words, hype has really gone ahead of itself, especially in areas like healthcare, which we really need to take a conservative approach in. One of the things that I realized in the healthcare space, my background in a past life was very much focused on media and technology. And that, as you guys may know, is very much about, the faster the better. Everything that's a year or 2 years old is oftentimes stale in the market. And when I started working in the healthcare space with technology, everything seemed extremely slow moving, extremely conservative, and I didn't fully understand kind of those concepts until it kind of sunk into me that, well, patient lives are at stake, and there's so many different parties in this ecosystem that all need to come together to make sure of things like safety and efficacy, and that is why the conservative approach is obviously much more apt and appropriate for the healthcare technology space. And so how that applies in terms of AI, I would say, people need to, in general, slow down in terms of understanding what AI can do for them in the short term. It really needs to focus on specific use cases as opposed to kind of general concepts of, everything gets solved because there's these new generative AI technologies. The second concept is really about assistive versus diagnostic, and some of the others have touched upon this as well, which is that if you look at AI tools as assistive technologies right now in the healthcare space, where the final decision maker is still a human, that becomes much more manageable and practical in the short and medium term, I would say. We're still a ways from having AI be a fully diagnostic system where you can just offload everything to AI. And I think that's an important concept, both in terms of how solutions are developed and how they're presented to entities in the market. The other thing that's challenging about AI is it's one of the first, if not the first technology in a long time where we are outsourcing really that strategic thought process to a computer and not putting the human in the middle of everything. A lot of other technology innovations up until now have really still relied on humans, fully to be the decision maker. And here we're starting to push that out, and that's something that we need to be very careful about, because in healthcare, 60% is not good enough. You cannot have a solution that works, part of the time or not be fully precise. And that drive toward precision is something that everybody really needs to focus on. And what that means is that we need to really focus on use cases that are very, very precise and very specific in nature. If we look at just generally the broad areas of AI in healthcare, if we put if we bucket them into certain categories, you have the life sciences, you have the patient-facing, you have the clinician-facing, you have the administrative, and you have the analytics buckets, if you will, kind of as a broad categorization. And in general, what we've seen is the administrative tools, for example, things like note-taking and being able to compose proposals and those kinds of applications, really taking the forefront in terms of both the maturity of the solutions and the number of solutions that exist out there. And we continue to see those areas define kind of the leading edge, if you will, of a lot of AI applications. Image recognition, as some of the panelists have also talked about, in a very precise sense as an assistive tool, we've also seen quite a bit of traction in. Some of the other areas are more visionary in nature; they'll catch up, but they're still a little bit a ways away from actual implementation and real world kind of delivery into the market. So one of the things I wanted to just kind of leave with is to say, looking at AI strategies in general and AI implementations, it's really about the preciseness of the use case and really developing a very targeted set of deliverables that the AI can help with, as opposed to looking at it kind of broadly. And that's what will allow us to move forward kind of slowly but surely in making sure AI is both helping the industry, but also maintaining that balance of pushing forward, but also safety and making sure that the patient care experience it benefits and doesn't get hurt.
All right. Hey, that was excellent. I'm going to do my best here to moderate a couple of questions for the panelists. Again, if any of you have a question you'd like to pose, please bring it to us. So I'm going to start, Andy, maybe with the last concept about building trust and confidence in the industry. A lot of caution, a lot of promise, a lot of optimism, and then ask a couple questions about the intersection of those that are innovating and those industry leaders that have challenges of really implementing, deploying, and scaling various innovation. But when you look at the role of, say, federal government versus industry associations to build trust and confidence in the industry, how do you think about that? And then, Dr. Reich, I'm going to ask you the same question.
It doesn't matter. I think we need to look at everything as a partnership. Especially in healthcare, because there's so many different aspects that come into the patient care experience. Certainly the role of government is to set those guardrails in general, which is, okay, broadly, you will use the data for this purpose, you will not use the data for this other purpose, nefarious purposes, misleading purposes, those kinds of things like that. But at the end of the day, they only have a broad strokes approach, right? You can dictate things through regulation, but the devil is in the details, and that's really where kind of you have I would call it the citizen organizations to basically monitor that those policies are being adhered to. So while the government is there to really drive the you will use this for the benefit, you really need to make sure that the industry really adopts those guardrails properly. And, I would say industry being not specific companies, but specific companies in conjunction with, for example, organizations, nonprofits or industry associations that help ensure that those kinds of things get met. So, I guess I would look at it from an ecosystem perspective, and that every player in the ecosystem has that checks and balances with the others. And that's, I think, how you really build that trust.
Yeah, makes a lot of sense.
So I'll comment as well. But really, it's in so many ways about governance, but we don't want the government to regulate us out of existence before we exist. So we have to work together in that respect. And actually, yesterday in this very same room was a meeting of the Consortium for Healthcare AI, CHAI or CHAI. And the way this seems to be coming together, at least in a U.S. perspective, is that the standards that are being promulgated by a combination of industry, government, and the academic health systems that are leading in development in this area with industry startups and industry stalwarts, I might say, is that a set of guidelines and criteria coming together. In fact, they have three major work groups. I think one of them is called Model Card, another one is Predictive Analytics Group, another one is Generative AI. And the idea will be that if somebody is developing a new product, whether it's internally within an organization or taking into account something which is being sold by a vendor, that will be in a place where there will be some degree of safety and it fits into an organization's governance. And so when we think about it, it has to be safe, it has to be effective, it has to be equitable. There are so many things about it that need to be done well that I wouldn't be surprised if we eventually end up developing, perhaps out of CHAI's efforts, out of what Microsoft is doing with another group called Train, which is based more on the technical, is almost like a joint commission for AI. That we will have an organization, an independent organization that will be able to certify that a product meets the criteria. Whether that comes to pass or not, whether my crystal ball is cloudy or broken, we'll have to see, but I think that's the path forward.
Yeah. Maybe relating that to certification of EHRs even before the High-Tech Act and then being able to do that on behalf of the industry, but led by this combination of both industry associations as well as federal government. I'm going to pivot to talk a little bit about value proposition. We'll talk about sticky subject, maybe ROI, and the relationship with innovators and those that are deploying those innovations. And maybe Sanjay, ask you, when you talk to health systems about the technologies that you have and the promise of them to really drive better patient care as well as financial return, how are you finding that those organizations are approaching financial return and economics of implementing and deploying those solutions?
Thanks for the question. Hello? Thanks for the question. So, yeah, it's a really big point. I think AI, so I'm talking more from the radiology perspective where our company is focused on, initially was all about, I've got a solution, and sometimes there was technology developed for the sake of developing technology. I think healthcare providers found that, initially found it novel and nice, but the excitement and the hype quickly wore off. And I think providers, clinicians are now becoming much more discerning. What is the technology and what problem is it solving? AI needs to be able to solve a problem or improve a clinical pathway to really have value for the physician, for the healthcare service. It's of no use to have AI for the sake of having AI. And I think the companies that are doing that are then able to build that evidence to show that the AI can be reimbursed, which then creates another means of value for the healthcare system. So one, they're getting value from using the AI, whether it's better clinical decision-making, as I spoke to earlier, improving patient outcomes, whether it's improving or streamlining the care pathway. But then on the monetary side or the financial side, if there's reimbursement associated, getting that value back into the healthcare system or getting it to the physicians. So if their work is reduced by using AI, they receive financial benefit on another means through reimbursement. And I think those are the real key things. You've got to solve a problem, and then you've got to have some monetary aspect associated with it for AI to really become mainstay in healthcare systems.
And then maybe Dr. Reich on the other side of that.
Well, and it's not so much a joke. It's sort of a bit of old trauma for me, as people would come to me when I was chair of anesthesiology and say, well, we have this drug, and if we use this drug, people will be ready to leave the recovery room 10 minutes sooner. And if you take the total budget for the recovery room over the course of a year and divide it by the number of minutes, a minute of recovery room time is worth this many dollars. So if it's $5 a minute and the drug costs, whatever, $20, and you save me X number of minutes, you save me this much, that's complete BS. My mother-in-law calls that bullspit. And so why? Why is that wrong? Well, because I needed the same number of nurses. I needed pretty much the same amount of electricity. I haven't really done much except spend a little bit more on a drug. So what is a real ROI? Something which helps us do things more efficiently, so we need fewer people. So if radiologists could read 20 exams instead of 10 in a unit time, that'd be a productivity measure. If there's something, for example, like opportunistic scanning that we're talking about that might identify osteoporosis, very apropos of today, it's an epidemic in older people in the U.S. It predominantly affects women, like 80%. And so if we were able to do better opportunistic screening and get people into treatment programs, it's good for the patient, good for population health metrics, and there's even in the U.S. something called a 340B drug discount benefit. So I could see a real financial ROI and a viable business plan for opportunistic scanning. Frankly, for fatty liver disease, not yet, but it may be coming. The key is to think, I think, very much like the health systems. The UK is very different than Western Europe, is very different than the US. And so the ROI and the value proposition has to be tailored again to local conditions.
Yeah, similar to your example use on the data side of the 6 areas under the curve. Andy, question for you. Intriguing, helpful engineering, and it feels like, if I'm describing this right, you've got this network of engineers and developers, et cetera, that are working together and collaborating on certain projects that are in demand by another side, let's call that, of a two-sided marketplace. How does the marketplace think about tools or systems or innovations that involve AI when they're working with you as sort of the coordinator, collaborator of that?
Well, I mean, am I on? AI, I mean, is pervasive across all discussions around everything right now. And, it's really about, as we talked in this panel, channeling it properly, right? And so, for example, in companies, as they look at, how AI can benefit them and how the community can benefit them with AI applications, obviously there's a lot of talk about how AI can improve a particular company's products or services, whether it's through, efficacy or predictive or whatever it is. But there's a couple of other areas that AI can actually help in terms of products and solutions that are market-facing that, can get a boost. The first one is in data and analytics, right? So oftentimes, obviously, these companies and these solutions, they do pilot programs with, health systems or whoever, and there's an enormous amount of data that's coming back in, from those pilot programs. Now, crunching that data is typically, a whole data team or whoever. AI can help with some of that crunching. Now, it can't necessarily, talk about or make decisions around some of these areas that, about is there, a positive ROI or other benefit as a final result or final conclusion, but it can certainly help in a lot of data processing type of tasks. The second one is in relation to matching. And so oftentimes a solution, as we talked about, has very specific use case applications. And those use cases can even be broken down to, particular profiles of clients as opposed to generally across a use case. And that profile could be, whether it's a demographic profile or a regional profile or whatever it is. And finding that right match of where a product or solution can go and potentially get traction and meaningful results, that is a process in and of itself. And so AI can help with some of that profiling and basically suggestive matching, if you will, of companies trying to find ways to move forward. So kind of really across those three areas, AI can help, whether it's in improving the product for predictive and efficiency, whether it's in data crunching, or whether it's in looking at kind of matching partnerships that can help.
It makes sense. I'm very glad I'm not a CIO in today's world anymore. With almost 1,000 FDA-approved AI algorithms that are out there today, and my guess is each one requires a very different data set that's got to be in pretty good shape, as you just described, in order to really take advantage of that algorithm. What advice, maybe to the three of you, maybe starting with you, Sanjay, and working right to left, do you have for the companies, the innovators that are out there, about the readiness and the state of where we are with just respect to data to power some of these advanced algorithms that can be used today to drive benefit? And are we spending enough money internally in organizations? And is it your observation that companies or organizations, associations, healthcare providers are ready to deploy the very innovations that could drive value?
Yeah, great question. And it's there's obviously a lot of aspects or a lot of things to consider with regard to that question. I would say that healthcare providers are becoming or getting on the path to become more amenable, open to adapting to adopting AI. But I think we're still very much in the infancy of this journey. A lot of the data that's locked up or held in hospitals is still in different silos. It's still very unstructured. And I think a lot of this data needs to be tapped into to make it more usable and to unlock the insights that we don't see at first hand. I think AI is brilliant at doing that, but there needs to be greater collaboration between the providers and companies developing AI solutions, whether it's for image analysis, such as we're doing, whether it's on the operational side, or whether as we go down, as the technology evolves, as the openness and the adoption increases, we move into using AI to maybe predict disease earlier, predict disease better. A lot of these types of solutions, we see a lot of research studies around them, but I think the commercial adoption is still very much in its infancy. And I think once we've mastered or figured out a way to tap into these different silos and bring different data sources, multimodal data together, I think that will really enhance the delivery of patient care and ultimately improve patient care.
So some maturity still to be gleaned by
a lot more maturity. I think it's still very early in the AI journey.
Want to add on to that, Andy, or agree with that? Or
yeah, from my perspective, it's all about the data, right? And so, AI is nothing without the underlying data that's powering that AI.
And that should be a first step in maturity toward leveraging some of these advanced technologies.
Yeah, and unfortunately, kind of in working with a lot of kind of healthcare companies, I have yet to encounter a company that does not have an issue with their data and what I call digital readiness, whether they admit it or not. And so getting kind of that foundational layer first and foremost is what's critical to building an AI program, an AI solution on top of. And companies really need to make sure that they understand that concept, that there is an infrastructure setup that needs to happen in their organization or one that they can leverage before they can meaningfully set up AI programs.
And then real quick, Dr. Reich, your health system is leveraging some of these tools today. When would you say was the time, 10 years ago, 20 years ago, that Northwell really began to invest in its data assets?
Mount Sinai put together what I called the Little Big Data Group back in 2016. We didn't even call it AI back then. So I think the point is it's a long journey, and that journey has to involve an obsessive amount of effort with the frontline team members in building use cases that actually work for them. There's so much alarm fatigue. There's so much in the way of positive predictions that are not true, a low positive predictive value, that one of the value streams that I saw yesterday at Chai that made me very happy is that in addition to the accuracy of a model, the positive predictive value based upon the sensitivity becomes an important thing. And then finally, just to finish up, when it comes to AI, we have to get out of our own heads when we're creating a project and put our heads in the people that are going to be the potential users of it and say, what is the real value proposition? We tend to get caught up in our own narratives and get excited about an idea that we have, but have we really done that focused research to show what the potential users of that technology will actually experience when they try to implement it, and how affordable it is? Free isn't free if you have to integrate a product into a very complex environment. Thank you.
That's a great close, Mount Sinai. My apologies. Okay, give these three gentlemen a round of applause.